Welcome again. In our National Neurofibromatosis Centre in London, we work with a team of clinicians from very different disciplines, some of whom you'll have the opportunity to meet today, and with our specialist nurses. And we feel, I know many of you have got children with NF1, but we feel that we need to look after people and work with them from birth until old age. So in the same unit, we see people who are children and adults. And our great aim is to work in partnership, because you will be expert about your condition in ways that we cannot be. So today, as I said, is a whistle-stop tour through NF1. So I'm a clinician, but as you know, it's an inherited condition, and you either get it as a new mutation, or you get it because you've inherited it from one of your parents. When the NF1 gene is faulty, the protein, neurofibromin, doesn't work properly. When it's working properly, it controls the way cells grow and divide. Can you not hear me?
No, can I just make another announcement, just because there's not many people next door?
Oh.
Although I was expecting lots of you, but if there's anyone that wants to be in NF2 and schwannomatosis, then you go round to the next room. I'm sure there won't be a flood leaving the class, but if anyone thinks they're in the wrong place, then we're around the corner.
Okay, so as I was saying, the neurofibromin, the protein, controls the way our cells divide and grow. And when the gene is faulty, then all the signals that are needed cannot work as well as they do normally. And the way that I think about it is that in London we have a very large railway station called Clapham Junction, and it controls the signals throughout the south of England. And so the tracks go off and divide and take trains all around the south of England. And if the signals aren't working properly, as you can imagine in London that happens quite frequently, then the trains are delayed. So the signals are there, but they're a little bit faulty. So what about diagnosis? Well, I'm sure you are expert at this. As you know, you need 2 out of a list of things. So this is a condition that affects the skin, the bone, the eye, the nervous system. And of course, as we've said, it runs in families. So you see the 2 delightful young ladies at the top. They have inherited the NF1 from their father. And what I want to stress is that it's a variable condition. So as you can see, they don't have many visible neurofibromas. Their father does. So just because your parent has something doesn't mean to say you're going to get it. As regards the eye, you can see those brown leash nodules on the iris, the coloured bit of the eye. They are absolutely harmless. They're a sign. And Leash was a doddery old 85-year-old when he had a big feast in Vienna that we went to, and they gave him the Viennese Empire Medal for just for describing this feature. So cafe au lait patches are actually key. If you're a parent, you notice them when your kid is young, an infant or a baby. Sometimes they fade, so if they come to our clinic as adults, we may not see them, and that's why I think the parent is crucial, because I can turn to our parent and say, did your child have multiple cafe au lait when they were young? And if they say yes, that's really helpful for the diagnosis, so keep that in your head. Of course, you may get freckling. You get the neurofibromas usually around teenage years, but sometimes a little earlier. And the number, as I said, varies. The plexiform ones are the more diffuse ones that cause people problems. And the smaller ones are the ones that give the cosmetic problems. I've just shown you down there, just at the bottom, a long bone problem where the bone has not formed properly. You've got a pseudarthrosis, so a false joint, and the bone is prone to fracture. And I'm going to talk about the optic pathway gliomas that may impair vision a bit later on. So Heather Radke at lunchtime is going to talk about prenatal testing. But suffice it to say, in England, we test the NF1 gene when the diagnosis isn't certain, and we have available prenatal testing. And if you're interested, Heather will talk to you about this at lunchtime. So learning is, as you well know, one of the major features of the condition and a cause of much heartache. And I'm very pleased that we're going to have Jonathan Payne with us from Australia, working with Kathy North now in Melbourne. And you'll be able to talk to him when he comes on the panel. As you know, many people function normally. We've got people who are professors, who are lawyers, but some people do have problems with learning. And they often have specific problems. So those of you who know I didn't get on the bucking bronco will know that I'm pretty uncoordinated. So it's not just NF1, but there may be problems with visuospatial awareness, concentration, coordination, reading, etc. And our colleagues have shown that people do have the attention deficit hyperactivity disorder, and some have autistic spectrum disorder. And some just simply have behavioral problems. They don't respond to the normal nonverbal cues. So if I see you going to sleep, I know I've got to hurry on and talk about something else. They may find that slightly more different. You will be aware that the group in America, in Holland, and in Australia have tried statins, and it really hasn't shown a significant benefit. But I think Jonathan might tell you about the new possibilities. So do not forget that learning problems don't go away. And Mary, who's here with me, who's our nurse, and I did a study in our clinic and found 10% of our adults could not read or write. And people didn't really want to come forward to tell us that. They felt ashamed. So we make a big deal about finding about literacy in people. They may have writing or spelling problems. Usually their writing's better than mine. They may have speech problems, and you can see there's somebody who's had some writing problems. They find it difficult to space their letters. They find it difficult to put in capitals and small letters. So that's one of the features we look at in the adult clinic. So what about the neurofibromas? Well, we're going to be very lucky to have Pierre Wolkenstein with us on the panel, an expert in neurofibromas from Paris. So basically, neurofibromas are lumps on nerve coverings, and they either pop out or they run along the nerve covering itself. So if you look down, you will see the copper wire with the coverings around it. Our nerve sheaths are a little bit more sophisticated than that, but it's the same sort of thing, keeping the nerve safe. So the major cell in a neurofibroma is the Schwann cell. It's a normal nerve cell. We've all got them. But because neurofibroma is faulty, remember the signals in Clapham Junction, the cells grow a bit more and form lumps. So I think we feel the major fruit in there is the blueberry. So that's the Schwann cell. But there are lots of other cells within it, and there are lots of other fruits within the blueberry, and that's what a neurofibroma looks like, not quite with a fruit salad. And what the Schwann cells do is wrap around the nerve to keep it safe. And you see down at the bottom a wrap keeping the filling safe. It's the same sort of principle. So the ones at the top are the skin neurofibromas. Obviously, they're a cosmetic problem, and you can tell me that better than I can tell you. But they do never become cancerous. The ones just to the right are ones under the skin, and very rarely, very, very rarely, they may become cancerous, but they can press on nerves and cause neurological problems that my colleague Vicky Williams, who's here, will see. And the one at the bottom is a plexiform neurofibroma, quite a big one. But actually, that patient had that removed and has done very well. So what sort of symptoms can they cause? What sort of symptoms can they cause that make us think about, would this be suitable to send to Birgitta? So obviously cosmetic. Neurological symptoms, weakness, numbness, tingling. Bladder and bowel symptoms. Some people have difficulty breathing or swallowing if they're right up in the neck. And very few people, as Mary and I have seen, will actually have significant bleeding. And of course, they're prone to infection. So a lot of issues that upset people. So here's an example. The long thing down here is your spinal cord, yeah? And that's where all the nerves come off to serve your arms and legs. And right at the top, you see a neurofibroma. These are two different people. And you can see it's narrowed it. So the person on the left came to us and they had weakness, numbness, they had trouble passing urine. And that person needed to go to my friend Nick Thomas, our neurosurgeon, to have surgery to have it removed. But this young lady, very similar scan, has been followed under our unit for about 8 or 9 years, and she's absolutely fine. She's just had a baby. So again, showing the variability of the disease and the need to see experts so you don't have surgery or other treatment unnecessarily. So what sort of things do our nurses like Mary talk about on the phone? Well, we have a little card that we give our patients, and it says, help. What sort of things do you want to tell us about? And particularly if you're an adult, because children's neurofibromas can go rapidly during puberty, but if you've had something that's soft and it becomes hard like a piece of wood, if it's enlarging rapidly, so it didn't look like that last month, it's obviously larger. Or if you've got neurological symptoms or persistent pain that might wake you at night, then we need to check it out. The vast majority of these are benign. They are not cancerous, but very rarely they are, and we need to know about it. And we ask our patients over the phone to think about things in terms of fruit and vegetable, because if you say to us, it's now the size of a pea, we're not going to be that worried. If you say, well, it's gone from a pea to a walnut or an orange, we'll say, come in, we need to check it out. So this is a much more modern picture. This is a young man with a pain in his back, and he's got a neurofibroma in the sacrum, and the PET has very helpfully showed up in that red picture where the surgeon needs to focus his biopsy. So vision is crucial, particularly in young children, and we have Bob Listenik, one of the pioneers in looking at optic pathway glioma, with us later on. So the message is the best way to look for optic pathway glioma is with very good vision testing from very early on, up till at least the age of 7, preferably 10, and a little bit longer if you want. But if you haven't got an optic pathway glioma by the age of 7, it's vanishingly unlikely that you'll get one. So all this shows the sorts of vision testing we do depending on your age, and colour vision testing is also important. So if you do have an optic pathway glioma, most of them don't cause symptoms, and we see quite a lot of adults that we find incidentally. If they do cause symptoms, they most likely need treatment when the child is under the age of 6. And from Mike Fisher's work, we've seen that usually if they're going to need treatment, they do so within 3 years of presentation. We never use radiotherapy. But we do use chemotherapy with vincristine and carboplatin. And I thought I'd just put at the bottom what's happened, because we see adults, so we see people right the way through. Well, the vast majority of our adults have good vision so that they're able to drive, even if they've been treated. But there is a small group, 6%, who have very severe visual impairment. So if you're looking right forward, many people cope very well in adulthood. People often tell us that they're very worried about brain tumor, and we have about 100 people with brain tumors in our unit. We do not advocate people having regular MR imaging. You can have a brain MRI, it can be fine, and then 5 months later you've got a problem. So it's all about knowing you, knowing your child, and knowing what's different for you. And again, this varies. These are 2 sisters. The message I want is most of the people that we've got with these gliomas have very stable disease. They do not need treatment. And the girl with the one on the left did have a lot of problems, but her sister has been absolutely fine for years. So the message is, if you get something that's unusual for you, a very unusual headache, not one that we all get, then check it out. So headache, my colleague Dr. Afridi did a study and found that headaches are really common in NF1, particularly migraine. And obviously you may have your neurologist sorting out very difficult headache, and Dr. Williams and Dr. Lascelles do that for us. But actually, our nurses give you simple advice, and I'm sure Mary at lunchtime will be able to help you with this if you want simple advice. And it's all the things that all of us fail to do. Relax, sleep, eat regularly, don't have too much Coca-Cola or caffeine, and think about having too many painkillers, because actually too many painkillers can also cause problems. Sleep. Those of us who are jet-lagged are thinking about it now. But Dr. Ferner in our unit, sorry, yeah, sure, yeah. I'm trying to be Gareth. Dr. Ferner in our unit has shown that people who have NF1 have difficulty sleeping, and they may have difficulty getting to sleep, get disturbed sleep, or they may wake early. And some of you may notice your partner snores heavily, or some people with NF snore heavily, sometimes because they've got neurofibromas in their neck. And people may have low moods, they may be on drugs that disrupt sleeping, they may get restless legs. There are all sorts of things, and they may get pain, as Dr. Williams will talk about later. So, some recent associations. People say to us if they knock their hand, they may get excruciating pain, a bit like they've hit it with a hammer. And that's because you can see a little purplish thing, a glomus tumor. And these are just benign things. They control temperature, but they're very, very painful. If you remove them, they're no problem. Gareth and others have shown that breast cancer is a higher risk in people under 50. So we start screening age 40. And many people with gut symptoms simply have anxiety or minor problems, but occasionally people with severe pain or change in bowel habit or bleeding have these gastrointestinal stromal tumors that require surgery. So our patients ask us, because we found in our paper, our local newspaper, that there are about a third of people in the young age group have tattoos now, and our patients say, do tattoos cause more neurofibromas? And the answer is, we think not. This person has a couple of neurofibromas. If you look at the eye, there's one just to the right of that. So we don't think it's a problem. So, finally, onto surveillance. We see our children every year, and the local pediatrician sees them every year as well. So they're seen every 6 months. And we go over all the things I've mentioned: development and behavior, schooling, blood pressure, skin, bone, eyes. And we think about sleep and headache. They're common problems, and they can help quality of life. What about our adults? Well, some people like to look after themselves, so we give them home blood pressure kits. We check bone, we check the skin, and we do baseline vision when about the age they want to drive. In England, it's not till 17. We think again about sleep and headaches, and remember about the literacy program. And of course, it's about emotional well-being, and that's where our psychiatrist, Dr. Santhouse, our clinical nurse specialists, and our psychologists come into play. So Mary's here today, but they work as advocates, both in the hospital and outside in the community with our patients. They also triage symptoms so people don't get unnecessarily worried. And they have specific groups, people over 50, so people my age get support, because they're often a forgotten group. We think about carers, because carers carry the burden of looking after people with NF1. And of course, we think about transition groups, because that's the age when we want to give people independence, information, and ability to control their own symptoms and run their own lives. So I want to thank all our nurses, and Mary's here, and I want to thank all our clinicians, because they're the ones who do the great job for us. So I'm going to leave you with our patient, because it's the patient who's key to all this. And he said, I'm now 39. I've learned I'm no different from anyone else. I deserve the same chances and respect as anyone else with or without NF. I did feel for a long time that NF had kicked me in the teeth, but actually it was the ignorance of society. So thank you very much.